Alright, so giving this IV piggyback med. So, alright, so I've already done all of her medication checks and everything. I've done her medication right, the right, patient, right drug, right route, right time, right reason, right response, right dose, everything like that. I've already asked her name, date of birth to confirm. So I have the bag of the med already. I have, and I also have a bag of 1,000 milliliters of normal saline as my primary. That's hanging already. So first thing I'm gonna do is this is already hanging up primary. So this has normal saline in it, and I have my secondary now. Okay. I don't actually have a bag to prime, so I apologize. So what I'm gonna go ahead and do, I've already checked the patency of the IV and everything like that. I'm gonna clean off this hub. This is the hub farthest away from the patient. I'm gonna go ahead and take this out. I'm wearing gloves, obviously, while I'm doing this. I'm gonna clean the hub of this. Right, okay. This tubing has already been primed, and the primary tubing is closed off right now. So, okay, so I'm just gonna hang this right here because this is our primary. So I'm gonna go ahead and open this clamp back up. I've already spiked my bag. Okay, I'm opening this clamp up. This clamp is open. I'm going to lower, so this is here. I'm lowering the secondary to let it back prime, to fill in the back. So I'm gonna let that normal saline get in that chamber, okay? And then I'm gonna go ahead and squeeze it. And then I'm gonna go ahead and close this up again. So now my tubing is back primed with the normal saline, and then the TPA med is already hung. So right now, my secondary, since I back primed it, is below it, right? Okay. Well, now what I do is take this, and here's the primary, and I'd hook that bag. So then this is going to be hanging lower than the secondary. So I'm going to go ahead and check all my lines, making sure everything's good. I'm going to label my tubing. I'm going to go ahead and open this up and let it flow. So I'm letting it flow. Making sure that everything's connected. Like I said, making sure everything's labeled, everything is connected to the patient correctly. And then I'm gonna go ahead and stay here, and I'm getting her vital signs every 15 minutes as well. So I would chart that. And then I also flushed her IV again, just to make sure that we're getting everything. That the infusion's actually going in her, like. So when I did that, I went ahead and charted. So I gave her education. I charted that I assessed her CT scan and orders prior to giving her. I reassessed her stroke scale for a baseline. I went ahead and assessed the IV site, and then flushed normal saline. And then I gave 62 milligrams, I gave 0.9 milligrams per kilogram of TPA via IV piggyback over 1 hour. I started at 9. I'm reassessing her vital signs every 15 minutes. I said we'll continue to monitor. And then I'd also assess her IV site 30 minutes after after the bag is done infusing as well, just to make sure that we're getting everything assessed. I went ahead and also charted that her stroke scale was a 32. So we are wanting to discuss the importance of her anticoagulant therapy to prevent clots from forming in future. Give her education on signs and symptoms of stroke, signs and symptoms of atrial fib, and when to go to the hospital, and then her med usage, side effects for calcium channel blockers and anticoagulant therapy. And I went ahead and charted that I did that already, and then I went ahead and charted that her call light was within reach and the bed was lower to the floor afterwards. So for report, I'm going to go ahead and just start that. So we have Mrs. Blossom. She's 57 years old. She came in with atrial fib with RVR. She had telemetry on. She got converted back to normal sinus rhythm with the calcium channel blocker, diazepam. When I entered the room, her daughter said she looked kind of funny, so I went ahead and did a stroke assessment. We ended up having to call code because she had left-sided facial droop, slurred speech, and she wasn't able to hold her left arm up for more than 3 seconds. So we went ahead and called a stroke code. Her stroke score was 32. We went ahead and got a stat CT. There was no obvious bleed in her brain, so we went ahead and gave her some oral suctioning, and the catheter is still beside her bed. I got 50 milliliters of clear sputum out. Some contraindications for a thrombolytic would be recent surgery, GI bleed within the last 3 months, excessive hypertension, evidence of cerebral hemorrhage. So she's a little hypertensive, but other than that, I went ahead and gave her some TPA, 0.9 milligrams per kilogram over 1 hour. And we've been doing every 15-minute vital sign checks and neuro checks. I've just stayed with her basically, just to monitor as closely as possible. Everything is charted. She's able to speak a little bit better. She still has a slur. She's still slightly weak, but now she's able to hold her arm up for 10 seconds. Her stroke scale is now a 6. We explained to her that because of her AFib, she probably had pulling in the atria, which caused her to clot, and then when we fixed her rhythm, she threw that clot and it traveled to her brain, and then the clot caused tissue death, which led to the ischemic stroke. She's going to be discharged today with some clopidogrel and aspirin and a calcium channel blocker. She has a follow-up appointment in 1 week to see a neurologist. So we also discussed the importance of keeping up with her follow-up appointments. Yeah. So her vital signs were her temp was 98.6, her heart rate was on 110, her respirations were 22, her blood pressure was 140 over 90, and her pulse ox was 96, and then she denied pain, and I already reassessed that as well before we leave. So she's in the bed right now with her call light in reach and the floor, her bed lower to the floor, and the wheels locked, and her daughter's at the bedside. So yeah, so she should be getting ready to be discharged pretty soon. So yeah, I have that infusion going. IV site's fine. I think that's it.